All right, let's just jump right into it. Welcome to this survival guide explainer, because right now, literally all around us, in the dirt we walk on, the food we eat, and sometimes right inside our own bodies, a hidden world of invaders is quietly going about its business. Today, we're profiling the ultimate clinical criminals, intestinal nematodes. Whether you're prepping for your boards or you're just fascinated by the sometimes terrifying reality of human biology, we've got the essential, high-yield intel you absolutely need to master this topic. So here's the game plan for today's Rogues Gallery. We've got Meet the Intestinal Invaders, Heavyweights, Ascaris, and Hookworm, the Infinite Loopers, Annoyances and Seafood Mistakes, and finally, those high-yield exam traps. Let's get to it. Section 1. Meet the Intestinal Invaders. Let's go ahead and set the scene for these microscopic heists happening right inside the human body. Okay, 400 million. Let that sink in for a second. That is the estimated number of people globally infected by just one of these nematodes, the hookworm. We aren't talking about some rare, exotic medical anomalies here. This is a massive, ongoing global health reality. So figuring out how these parasites operate, how they pull off their infections, and how we actually diagnose them, that's absolutely critical for clinical practice everywhere. Section 2, Heavyweights, Ascaris, and Hookworm. It's time to meet the biggest, baddest criminals on our list. Okay, this anatomical journey is honestly just insane. We're calling it the Ascaris lumbricoides heist. This thing is the largest intestinal nematode, growing up to a massive 40 centimeters. That's kind of like the length of your forearm. So here's how it works. You ingest embryonated eggs from contaminated soil. They hatch down in your duodenum, but they don't just hang out there. No, the larvae literally break through your gut wall, hop into your bloodstream, travel all the way up to your lungs, break into the alveoli, and then climb up your bronchial tree just so you can swallow them again. Only then do the adults actually mature in the small intestine. It's a wild, highly testable round-trip ticket. Now, the real crucial point here is what happens during that bizarre little lung vacation. Between days 9 and 12 of the migration, patients can develop Lafleur syndrome. This is an eosinophilic pneumonitis, so you're going to see a cough, some substernal discomfort, and these transient fleeting pulmonary infiltrates on an X-ray. But, and this is a major, major clinical pearl, you will not find eggs in a stool sample during this phase. Why? Well, because the worms are still busy migrating through the lungs. They aren't laying eggs down in the gut just yet. And once they do finally settle in the gut, a heavy infection is seriously no joke. Think about it. A bunch of 40-centimeter worms can easily get physically entangled, causing a mechanical small bowel obstruction, which is especially dangerous for kids. But it gets worse. An adult worm can actually wander up into the biliary tree, causing biliary colic, cholangitis, or even pancreatitis. In fact, biliary ascariasis is a super common surgical emergency in endemic areas. And it can completely mimic acute appendicitis. Wild, right? So let's contrast Ascaris with our other heavyweights. The hookworms, specifically Necator americanus and Ancylostoma duodenale. These guys, they don't wait for you to eat them. Filiform larvae in contaminated soil will just directly penetrate your bare skin, causing the super itchy rash known as ground itch. From there, they do the whole lung migration dance, get swallowed, and land in the small intestine. But unlike Ascaris, hookworms come armed with actual buccal teeth. They literally bite into the mucosa to actively drink your blood. So the major severe consequence we're watching out for here is hyperchromic microcytic iron deficiency anemia, along with eosinophilia. Section 3. The Infinite Loopers. We're shifting gears now from structural damage to something straight out of a sci-fi horror movie. We're talking about Strongyloides stercoralis. The thing that makes this nematode incredibly unique and honestly terrifying is auto-infection. Usually, parasites have to leave the host to finish their life cycle out in the environment. Not Strongyloides. The larvae can just mature right there inside the gut, penetrate the colonic wall or the perianal skin, and start the whole cycle all over again completely internally. It is literally the only major helminth that can clone itself indefinitely inside the exact same human host. And check out this alarming speed, 10 centimeters per hour. That translates into a pathognomonic clinical sign called larva currents. Basically, as the larvae physically race just underneath the skin during this auto-infection loop, usually around the buttocks, they create this intensely itchy, advancing red serpiginous track. You can literally sit there and watch the track extend, hour by hour. But here's the thing. Here's why Strongyloides is a total ticking time bomb. If a patient ever becomes immunocompromised, especially, and I mean especially if they're given glucocorticoids or have an HTLV1 infection, that infinite loop just kicks into massive overdrive. We call this hyperinfection syndrome. Massive numbers of larvae disseminate to the central nervous system, skin, lungs, and liver. And as they punch through the gut wall, they drag gut bacteria right along with them, leading to devastating gram-negative bacteremia and sepsis. The mortality rate is sky-high. That's exactly why even a completely asymptomatic strongyl maize infection absolutely must be treated with ivermectin, and why screening for eosinophilia before putting someone on steroids is so important. Section 4, Annoyances and Seafood Mistakes. Let's take a quick breath and transition to our next group of invaders. All right, let's compare two totally distinct bugs side by side. First up, trichuris, the whipworm. This one embeds itself in the colon. Heavy infections cause bloody diarrhea that can look a lot like IBD, and famously it causes rectal prolapse in kids because of the protracted tenesmus. You diagnose it by spotting these classic little lemon-shaped eggs. On the flip side, we have enterobius, the pinworm. This is your classic childhood annoyance in temperate climates. Gravid females literally crawl out at night to lay thousands of eggs, which causes maddening, keep you up all night perianal itching. You treat it with mebendazole, but listen up, you absolutely must treat the entire household at the same time to break the cycle. Now, you might be wondering how to spot it. Well, a standard stool O&P exam is completely useless for pinworm. Do not fall for that trap on exam day. The eggs are deposited directly on the perianal skin, not mixed into the feces. So you have to use the Scotch tape test, literally pressing tape right to the perianal region to catch those flattened oval eggs. And critically, it has to be done first thing in the morning, right before the patient takes a bath. Okay, let's talk about seafood mistakes. If you ingest anisakis from raw saltwater fish, we're talking sashimi, ceviche, pickled herring, the larvae penetrate your gastric mucosa within hours. It causes this violent upper abdominal pain that completely mimics an acute abdomen. And no, salting or marinating the fish does not kill it. Worse, you can't just pop a pill for this. The only cure is direct physical endoscopic extraction of the worm. Yikes. Now, contrast that with capillaria from raw freshwater fish. Kind of like strongyloides, capillaria triggers progressive autoinfection. This leads to a severe protein-losing enteropathy and muscle wasting that can actually be fatal. To fix it, you're looking at a grueling 20-day course of prolonged mebendazole. Section 5, High-Yield Exam Traps. Let's bring it all home. Time for a rapid-fire cheat sheet designed to save you on test day. Definitely lock these in. Number 1, in Loeffler's syndrome, the Ascaris worms are still chilling in the lungs, which means there are no eggs in the stool yet. 2, biliary ascariasis is a legit surgical emergency that rivals acute appendicitis. 3, if Ascaris causes a bowel obstruction, you need to use piperazine via an NG tube. It paralyzes the worms so they can naturally pass distally. And 4, always screen for eosinophilia before handing out glucocorticoids. You do not want to trigger a deadly strongyloides hyperinfection. Continuing with our cheat sheet, remember, a stool O&P is totally useless for pinworm. You've got to use that morning Scotch tape test instead. Also, when you do find pinworm, you must treat all household members at once and repeat the whole thing in 2 weeks, since the drugs don't actually kill the eggs. And for seafood, just know your water. Saltwater anisakiasis means an endoscopy, whereas freshwater tapillaria means a month of pills. So, having decoded the mechanics, the diagnostics, and the downright bizarre life cycles of these intestinal nematodes, it really leaves us with one final thought. Knowing the unseen world of these rogue invaders, from the 10-centimeter-an-hour racing strongyloids to the violent gastric reality of saltwater anisakis, will you ever look at a fresh sushi roll or even just take a barefoot walk in the soil the exact same way again? Thanks for joining me on this explainer. Stay curious, and I'll catch you next time.